We're almost to the end of endocrine pathology. Let's finish off by discussing three high-yield endocrine syndromes that are frequently tested on the USMLE. What are the four major clinical symptoms of carcinoid syndrome? Well, as you can see here, the major symptoms are recurrent diarrhea, cutaneous flushing, asthmatic wheezing, and right-sided valvular disease. Carcinoid syndrome is rare and caused by carcinoid tumors composed of neuroendocrine cells that secrete high levels of serotonin, which is responsible for the symptoms we discussed. If the tumor is limited to the GI tract, will carcinoid syndrome result? No, it won't. Why do you think this is? Serotonin will first pass through the liver and be metabolized to an inactive form before reaching the rest of the body. Hence, the symptoms of carcinoid syndrome are only seen with metastatic tumors or primary tumors outside of the GI tract. 2/3 of primary tumors are in the GI tract, most commonly in the small bowel. In fact, carcinoid tumor is the most common tumor of the appendix. But up to 1/4 have a primary location in the lungs. If a patient complains of these symptoms and is found to have a primary GI carcinoid tumor, you know immediately that the tumor has metastasized to the liver, since the liver clearly is no longer able to degrade the serotonin. The byproduct of serotonin that we can test for in the urine is 5-HIAA, which stands for 5-hydroxyindole acetic acid, and these patients undergo extensive imaging studies to define the tumor burden. Similar to the rule of tens we discussed for pheochromocytomas, carcinoid has this rule of 1/3. 1/3 of tumors metastasize, 1/3 present with a second malignancy, and 1/3 of tumors have multiple primaries. Treatment is usually with octreotide for symptom control. Zollinger-Ellison syndrome occurs in the setting of a gastrin-secreting tumor, or gastrinoma, in the pancreas or duodenum. Because there is hypersecretion of gastrin, we observe the effects of that hormone, namely hypersecretion of acid leading to recurrent ulcers and rugal thickening in the stomach or small intestine that can be observed on endoscopy. In fact, if a patient presents with ulcers in the distal small bowel, this is virtually pathognomonic for ZE syndrome, as normal physiologic acid secretion is insufficient to cause perforation that distally. You'll hear more about gastrin and other digestive hormones in the gastrointestinal lectures. Additionally, this tumor may occur as part of the MEN type 1 syndrome, which is our next topic. MEN, or multiple endocrine neoplasia, is the name for a number of different genetic syndromes that you should be intimately familiar with. They are not very common in real life, but they do show up on many exams. You may want to organize your thinking about MEN using the mnemonic on the right. MEN1 has the 3 P's and 0 M's, MEN2A has 2 P's and 1 M, and MEN2B has 1 P and 2 M's. I'll talk about what the M's are in a little bit. MEN1, also known as Wermer's syndrome, consists of 3 tumors each starting with P: parathyroid tumors, pituitary tumors, and pancreatic endocrine tumors such as gastrinomas, i.e. Zollinger-Ellison syndrome, insulinomas, VIPomas, and glucagonomas. The pituitary tumor type is similar to the normal population, usually prolactinoma and less commonly a growth hormone secreting tumor. Frequently, patients will present with kidney stones and stomach ulcers, and diagnostic workup eventually reveals the syndrome. And why do these patients have kidney stones? That's right, because of the hyperparathyroidism. MEN2A and MEN2B are grouped together because both involve medullary thyroid carcinoma, or MTC, which is one of the M's I mentioned earlier. MEN2A, also known as Sippel's syndrome, has 2 tumors in addition to MTC that both start with P: pheochromocytoma and parathyroid tumors. Hence, MEN2A consists of 2 P's and 1 M. MEN2B, on the other hand, also has MTC, a tumor starting with a P, that's pheochromocytoma, and another tumor starting with M, namely mucosal ganglioneuromas, associated with marfanoid habitus. Hence, MEN2B is associated with 1 P and 2 M's. All MEN syndromes involve autosomal dominant inheritance. The MEN2A and 2B syndromes are specifically associated with the RET gene. Before we leave endocrine pathology, let's try our hands at a couple boards type questions. A 19-year-old man describes an interesting constellation of symptoms he has had over the past 8 months, including 15-pound weight loss, nausea and vomiting, a loss of desire to eat, and progressive weakness. Upon physical exam, you notice that there is increased pigmentation in the patient's elbow creases and his blood pressure is abnormally low. What is the most likely diagnosis? The patient probably has Addison's disease, or chronic primary adrenal insufficiency. His symptoms are due to insufficient cortisol levels, and the hyperpigmentation is due to increased POMC secondary to reduced cortisol negative feedback. Recall that POMC is the precursor for ACTH and MSH. What laboratory findings would you expect for levels of ACTH, cortisol, aldosterone, urine sodium, and urine potassium? ACTH would be high because of reduced cortisol negative feedback. Cortisol and aldosterone would be low due to primary adrenal insufficiency. Urine sodium would be high, and urine potassium would be low because of reduced aldosterone levels. A 30-year-old woman is diagnosed with a craniopharyngioma that compresses and induces atrophy of the posterior pituitary. How would the kidney respond, and how would you treat her condition? First, we need to remember the hormones produced by the posterior pituitary, ADH and oxytocin. Only ADH influences kidney function. Specifically, ADH binds the V2 receptors in the distal convoluted tubules and collecting ducts to increase expression of aquaporin 2 channels. Lack of ADH will reduce reabsorption of water, and therefore the patient has lost the ability to concentrate her urine. Her condition is called central diabetes insipidus. The treatment would be administration of desmopressin, a long-lasting ADH analog. And that's a wrap. Thank you for listening to the Endocrine Pathology lecture. Good luck!